Thanks, Angie. And thanks to you all for having me. So I'm going to tell you a little bit about Triple P, this parenting program that's a public health approach. So to get started, I don't like to do all the work. So I'm going to ask you a question. When we say parenting program, what comes to your mind? What do you classify? What do you think of? What comes to your minds when we say parenting program?
How to parent.
How to parent. Okay, so there's some skills that are shared with parents. What else?
Like a home visitor.
Home visiting? Yeah. You usually think long term, short term? Short term? Excellent. All right. Well, a lot of folks have in mind kind of this, many folks end up thinking about parenting classes or, particular things. And as we jump into Triple P, want to challenge the thought of Triple P being for very specific, only certain specific parents, or the idea that it needs to be one particular format. So we'll see that as we go. And part of this being, you hear Triple P parenting program, so you think about helping to teach people how to parent. At its core, that's what it is, but it's a little bit more than that. We're about a little bit more than supporting parents. So hang with me. We are about being part of the solution to the substance abuse concerns that we all have. The reason that many of you joined this group today about helping to solve the opioid crisis, help prevent substance abuse in kids and parents. We are about preventing violence, being part of the solution to preventing violence that we see across rural, urban, nobody gets away from it. We're about helping to prevent incarcerations in the system that we often find isn't helpful for kids, young kids, adults, so forth. We're about promoting school readiness for kids to be ready to learn and be active in that process. We're about supporting communities to develop adults that are contributing members of society, that are ready to work, ready to contribute, ready to use their talents out in the world and contribute back to the community. And we're about supporting healthy lifestyles from kids through adults, not only in mental, social, behavioral health, but in physical health as well. So you may be thinking to yourself, okay, that's a lot of lofty goals. What does a parenting program have to do with this? And really a lot of it, and this slide actually came from my boss at Triple P America. And when he had this light bulb, this realization that parents are really the change agents, that kids spend a lot of time with their parents. And so parents have the ability to put kids in environments that help them achieve their potential or not. And I'll give you the background that my boss is a lawyer and now leads a parenting program in the US. So the realities are that prevalence rates tell us every single family is impacted by social, emotional, or behavioral concerns. Dysfunctional concerns, not just a little bit here or there. Every business in our communities has employees that are affected by social, emotional, and behavioral health concerns. Our schools, our healthcare centers, and our communities are the ones that are bearing the cost of most of these social, emotional, behavioral concerns. But thus far, the folks that are primarily charged for addressing behavioral, social, emotional concerns are mental health professionals or behavioral health professionals, right? And the reality of that is that mental health services are often stigmatized. If you suggest to somebody that they should go seek counseling or that they should go seek into your local mental health organizations, oftentimes people don't take that quite so well, right? And we only have so many mental health professionals. We only have so many counselors and social workers and psychologists and psychiatrists. And so they touch relatively few families in a community. And part of what I think you're gonna hear from me today is that every family can benefit from some parenting support at some point. That I was having a conversation with two gentlemen at the beginning about the fact that we're all parents, and maybe we pick up a thing or two around parenting in this presentation today. And I saw a really fantastic mom at Starbucks this morning whose little one was running towards the door, and she kept going and leading her back and going and leading her back. And on my way out the door, she's like, one day I forget your carrier. And just looked at her, smiled, and said, it gets easier. And she's beautiful, and got a smile out of her. Every single one of us can use some parenting advice. And how many parents are there in the room? How many folks have kiddos? How many of you have had a question about what you do with this kiddo at some point in time? Yeah, right? Me too. I was sharing with Angie last night. I was well educated before I had my kiddo, right? In parenting, it's my support. I studied child and family psychology, and I was trained in Triple P. And people look at me and say, "You're gonna be the perfect parent," as I'm pregnant. I was like, nope. Principle number 4, realistic expectations. I won't be perfect. And I have questions, and I use tip sheets. So we all can use some help. And if we keep the idea of social, emotional, behavioral development and concerns only within our mental health field, we're not going to touch the majority of folks that could benefit from support. And then the last point on here that I want to highlight, and one of my messages for today, is prevention can ultimately be more cost effective if we can put in place prevention programs that are effective. Okay, so the next place I want to take you, step forward. When you think about public health concerns, what kind of concerns do you think about?
Related to parenting?
No, outside of that. Like if I just generally say, if you're outside this presentation, and we say, what are some public health concerns? What do public health people do? Or what do you think the general, many of you come from public health, but what do you think the general world thinks public health is about?
Communicable disease.
Communicable disease.
Yeah, the 10
Washing your
essential
hands,
services.
or
The 10 essential services, right? Yeah. Immunizations.
Immunizations.
Environmental safety.
yeah. Maybe, long ago, introducing car seats and seat belts and health safety, those kinds of things. But it's a little bit new for folks to think about offering parent support as a public health concern, or why you might have that. But there are some pretty big concerns out there: child maltreatment, substance abuse, even violence prevention that's coming into the public health world. So with Triple P, I got to work with some really cool psychologists along the way and in my early days of learning, who had this vision. We've done lots of research on how behavioral health type interventions, behavioral parent training specifically, much like Triple P is one of those, that can affect individual families. We see changes. You do Triple P with a family, and you see changes in their parenting practices. You see changes in child behavior. Lots of research on that. But can we affect community level rates by implementing a public health approach? U.S. population trial, which you'll see up here, suggests so. In South Carolina, they chose 18 counties, mid-sized counties, randomly assigned folks to counties to intervention and control. So there were 9 intervention counties where Triple P was rolled out at a systems level at a population health, public health approach, and 9 counties that were on a waitlist control. At the end of about a 4.5-year mark, the counties that had received Triple P had 13% fewer hospital-treated injuries. So these are either ER visits or hospitalizations that have a classification with child maltreatment. 21% fewer out-of-home placements, and 31% fewer substantiated cases of child maltreatment. This is not tracking what families received Triple P and what happened to those particular families that received Triple P. This is making Triple P available to the community and tracking prevalence rates the way we track them right now. So pretty phenomenal things that can happen not only at the individual level, but at those public health prevalence rates levels. So I want to take just a second to show you my really horrendous drawing skills. To talk a second about the idea of prevention, or why we might want to target every family. You're going to learn a few times in my presentation. At Triple P, we love our triangles and our pyramids. So if you kind of think about parenting as sailing a ship of parenting, for your kiddo here. So we have the parent and we have little kiddo, and we're sailing a ship on this parenting journey. And we're trying to lead, as parents, our children towards a life trajectory. And our life trajectory might have, extremely successful. The kid who finds a cure for cancer eventually, like our kids that are super successful. To the other extreme end that we really like to avoid, high dysfunction. So things like incarceration, significant substance use, not able to work, contribute back to society. So in our lives, we end up somewhere on this trajectory, And given that we have genetics and people have different, opportunities genetically to land differently on these paths, as part of that, or in conjunction with that, they also have the environment where this parent steers this ship, right? So if we just kind of take your average child, starting to grow up, heading on this life course to somewhere on this trajectory, and then we hit bumps in the road. We hit stressful times, maybe a parent loses a job, or there's a divorce, or we lose a family member, or, just life happens kind of things. The parents get stressed and we start moving a little bit over this way. If we're able to catch parents early in this life trajectory, so this is time on this side over here. If we catch them early in this path, it just takes a bit of a tweak, a little change of that rudder to get back on course and head up this way. So early prevention, we can do very brief things, minor shifts of the rudder, we're back on track for that child achieving their potential on this life trajectory. However, if we wait till that's gone and the child is much older, and this has been going on much longer, it takes a really significant shift in that rudder to gear back towards over this way. So the argument here is that if we can provide brief, early intervention, we've got much better chances of gearing parents on the track to help support their children achieving on the more successful side of life trajectory than to the dysfunctional side. Make any sense?
Yeah.
All right. Sometimes I talk too much, so I have to keep track of how much I'm going. All right, so you see my case a bit, right? Are you seeing my case a bit about why we might think about parenting support for every family early in life and making this available? I want to start walking you through how. So you're like, okay, this sounds great. How do we do this? What does this look like? So with Triple P, with parenting, when I first asked you that question, and we think about where parenting supports have its effects, we most often start up here in the home setting, right? So we do a parenting program and we expect things to change in homes. We see increased effective parenting, so we see more positive parenting, we see less coercive discipline, less harsh discipline, and that kind of thing. We see better child behavior. We see kids that are able to function well at home. We see better self-regulation. So kids making better decisions, parents making better decisions. And we see less stress for families in the home. That's where it starts. However, when we're able to have these effects at home with kids and parents, let's think about how that applies to other areas of our community. So let's go to a pediatric clinic. If parents have more effective parenting skills at home and kids are going better on this behavioral, emotional, social trajectory, we get fewer ACEs. We get fewer adverse childhood experiences for kids. Fewer cases of maltreatment if we go back to what we found in the prevalence rates, which we know have huge social, emotional, physical health trajectories later in life. We get better health for kids and families. Okay, let's jump to a child development center in our community. I know I have a couple of Head Start folks here, right? So we get better classroom behavior because the kids have better self-regulation. And the kids are getting that positive reinforcement at home and the limit setting at home. They come in better able to learn, both at our Child Development Center and our school, to uptake information, to engage. We talked a little bit in the slides on the population trial. We get fewer ER visits, fewer hospitalizations related to child maltreatment injuries. And workplace, really interesting thing. When parents have better skills to parent and their kids are better behaved, they show up at work more often. And they're more productive while they're at work because they got out the door without a huge battle. How many of you parents have ever had one of those mornings that's like, if I can just get the kids out the door, or oh my gosh, what a disaster that was trying to get out the door this morning. I won't make you raise your hand. But Miss PhD trained in Triple P, I had one of those about a month ago. And I was like, I self-regulated. I said, okay, this is what didn't go so well. This is what did well. Changed it, hadn't had one in another month. We get out the door, we're to school, we're great. When that can happen, I can show up ready to engage in my work much better than if I have been stressed all morning trying to get there. Nighttime, getting kids to sleep and getting them ready. There's some basic parenting skills that really affect, and that almost everybody with kids from 2 to 5 struggles with. If we can get our kids to sleep and in bed at a reasonable hour, first of all, we know their sleep period affects their behavior the next day, regardless of what parenting skills are happening. But if the parent can get their child to bed at a reasonable hour, then they can finish up the things they need to do and perhaps have a little time to themselves at night and get to bed themselves and get enough sleep so they can be productive. All right, so we can go through many places in the community. We talked about child welfare. Juvenile justice is another. When kids have better self-regulation and parents have better positive parenting, we see fewer kids end up in our juvenile justice system, in probation, incarceration, all of those kinds of things. So I'm seeing some head nods. You're starting to see how this sort of works at a whole community level. here's the point that I just want to say. We are about changing parents' behaviors. We're about changing child behavior. But we're also about community transformation and helping all these folks talk to each other. The other point that you'll see as we start talking about how Triple P is offered is that Triple P does not live in the juvenile justice office or in the mental health building or in the public health building alone. Triple P exists across all these agencies in a community. So parents have access to common evidence-based practice for parenting no matter where they go in the community. Okay, so when we think about how Triple P is delivered to families, it's not a one-size-fits-all type of approach. It's not that every parent needs this to survive. It's not a, prepping for parents, you need this particular class, and if your child has this, you need this. The idea is we have many different types of support for families at many different settings in many different formats. So families can connect to that information in a way that best suits their needs and their wants. So we have a pyramid. I told you about our triangles, right? We have a pyramid that outlays. We have 5 levels. Level 1 starts with a media and communication strategy because parents don't seek information if they don't know it exists. And they don't seek information if they feel like they're in trouble for seeking parenting support. So it's about destigmatizing, helping with accessibility, and knowing that parenting supports exist. Then we move up to level 2, where we have brief interventions for families. This looks like a 10-minute consultation with your pediatrician or your nurse practitioner or somebody in the pediatric office because you've come for your 2-year well visit with your child, and the pediatrician has just asked you, does he follow instructions when he wants to? And you're like, yes, but he doesn't follow them a lot of times. What the heck do I do? Or my child is 3. I know it's time for potty training, and I have no idea what to do with that. So common concerns that all families have that we may do this. I gave one example. This happens across many different locations. Head Starts, families come in, they have concerns, same type of thing. It also can be offered as a seminar. What do I do to raise confident, competent kids? What do I do to raise resilient kids? What is this positive parenting thing? We step it up to level 3 when families need a little bit more support. They need some practice. They need some extra help in creating personalized plans for what they're going to do to help solve their problems. But level 3 is only 3 to 4 sessions with families. So we're not talking about 8 to 10 sessions. We're not talking about a year-long parenting course. We're talking about 3 to 4 brief sessions to help that parent develop a plan and practice that plan and put it into place. Our levels 1 through 3, we really consider our preventative elements. And if we look at the research tells us that about 80% of families in a community can benefit from levels 1 to 3. They have some concerns with their kids. Sometimes, they can use a little bit of help and support. About 20% of families in our communities have a child with a behavioral health diagnosis, emotional behavioral health diagnosis. Those kids are more likely, and parents are more likely to need levels 4 and 5, where we're talking about 8 to 10 sessions with a family for level 4. When we enter level 5, we're talking maybe more about 15 to 20 sessions with a parent, where we delve much deeper into their concerns. We get a much better assessment of what's happening. And those are a little bit more your classic mental health, type concerns. Although level 4 doesn't only happen in mental health. It happens with folks, it happens in churches where we conduct groups because parents are comfortable coming there and those kinds of things. So I showed you a little bit about the population level effects, but I haven't shown you the research yet on the individual effects. So I just wanted to do that briefly here for all my folks in the room that want to know the research. So back in 2014, there were some folks that did a meta-analysis of all the research that had been done on triple P to date across levels. And this encompassed more than 16,000 children or families, the meta-analysis when you cross studies. And what we find is that triple P, pretty much levels 2 through 5, no matter what, we have at least a medium effect size on child behavior. So significantly changing child behavior. And our parenting skills changes for levels 3 and 4 start to approach the large effect size. And this is, like we said, all studies on triple P done across many different countries and across many different types of settings, many different low-income families, well-off families, and so forth. Okay, so moving just a little bit further on that how. So if I take you back for a second, we made the case for why, and then we started talking about how in engaging multiple community folks in this effort, not having it housed at one particular place, and the fact that we don't have a one-size-fits-all for families. But what are we teaching them? What are we actually trying to help parents with? How do we make these changes to achieve these community outcomes? Triple P is based in these 5 principles that you see. So no matter if you go to a 10-minute consultation with a pediatrician or you're in a 20-session intervention with a social worker, you are being encouraged as a parent to do these 5 things. Ensuring a safe and interesting environment, creating positive learning environments, using assertive discipline, having realistic expectations, and taking care of yourself as a parent. I could talk all day about just these 5 principles, but the idea is these themes and these principles then drive the strategies that I'm going to share in a second. And those strategies are adapted based on the age of the child. So these are important no matter whether your child was born yesterday or whether your child is 17 or 18 and getting ready to walk out the door to college. These are all the same types of things, but it looks a little bit different based on what expectations we have for kids at that time. So we start, very important start, with strategies for promotion and development. And this is an important part to fidelity. Have y'all heard the word fidelity in evidence-based programs? Yeah. Important part of the fidelity of triple P to start with these strategies. Because when parents come in and their child's misbehaving, they want to know what they do when their child misbehaves. We're going to get there next. But it's really important that they do some of these strategies first. Because when you do these first and then you manage misbehavior, you get exponentially better results. So we start with promoting positive relationships for families. So how do we encourage parents and kids to have better relationships? With brief quality time, with talking with children, and with affection. So just to give you a bit of a flavor, when I say quality time as a parent, what comes to your mind? One-on-one.
Without distractions.
Without distractions. And many families feel like I need to set aside an hour a day. Or I need to take a Saturday and we need to spend the whole day. If you think about the pressure, one-on-one time, no distractions for an hour or a whole day, it often turns into disaster. Quality time for triple P, I told you I was going to be real. Quality time for triple P, 30 seconds to 3 minutes. The idea is when a child approaches a parent to ask a question, to show the latest artwork they've done, when your teenagers want to tell you, Mom, listen to this new song. Listen to this new song I just found. To take 30 seconds to 3 minutes to put aside what you're doing focus, eye contact with that child, comment on what they've brought to you, help them answer the question, and then let them go and go back to what you were doing. Promotion of attachment in children learning, that they can get your attention when they need it. And a really useful strategy that if you're able to do that, the child learns they can let your attention go and go back to what they're doing, because the next time they come to you, you're going to answer them in that same way. So this is the strategy for when you have that 2-year-old that's pulling on your pants, mama, mama, mama. You say, just a minute, just a minute, just a minute, but mama, mama, mama. So it's the start. It's relationships. Then we talk about encouraging desirable behavior. How do we get more of the things we want to see from our kids? So this requires first that parents figure out what they want to see in their kids. Because so many times parents will tell you what they don't want to see. But we have to flip that to, if we're not seeing that, what do we want to see? What do we want to encourage? What do we want to teach our kids to do? And so we got some strategies for thinking about that. And we have to recognize that our kids weren't born knowing how to interact with other people. They're not born knowing their ABCs, 1, 2, 3s, and they're not born knowing how to communicate. They learn it primarily from watching you as parents. And so we've got some strategies for thinking about teaching particular skills for kids, including self-care skills here, So if we want our children to learn to dress themselves or to brush their teeth, there's some strategies here to help with those. And we wouldn't be a parenting program if we didn't talk about how to manage misbehavior. Once we have the positives in place, once we have worked on those kinds of things we just talked about, there are strategies for managing misbehavior. And I don't think I have it here, but we also have a pyramid that's upside down, a correct pyramid, not like that, where the tip is at the top. Managing misbehavior strategies fall at the top. We use them very infrequently, and we use those positive strategies much more often. And that's what we're aiming to help parents do. That's how we get more positive parenting, less coercive parenting, and less need for these strategies right here. But they're there for when we need them. Okay. The other point that I just want to highlight about Triple P is that aside from the principles that we're teaching parents and the not one size fits all multiple access points for parents of differing intensity levels and in different formats, we base our program on 2 other key tenets. One is minimal sufficiency, which means we only want to provide parents with the support that they need to make the changes. This is why it's not the case that every family needs 8 sessions of parenting group. Some families benefit from just the 10 sessions. But we want to have options available so that families that need that extra support can have it. Other than minimal sufficiency, the other one to point out is self-regulation. So we want, at the end of Triple P, for that family to feel like they have better skills, that they have the confidence to implement these, and that my favorite is personal agency, that they take responsibility for doing this. And helping to encourage, this is done in many ways. The Triple P practitioner doesn't tell the parents what their goals are. The Triple P practitioner doesn't tell them which of these 17 strategies they're going to use. They share information and encourage the parent to make informed decisions. They facilitate an informed decision-making process that not only helps with parenting decisions, but decisions in other areas of life as well. Core tenet, when we use this, it ends up in a reduced need for support over time. So back when I first started doing Triple P, shows like Super Nanny and Nanny 911 were really popular. Anybody remember those? I probably got some people too young to remember those in here too. But at the end of the day of those shows, who got credit for the changes? The nanny, right? Super Nanny, or the nanny that came in with Nanny 911, right? She changed our family. At the end of Triple P, what we want the family, the parent to be able to say is, I changed my family. And I can do it next time this happens as well. Okay, it's my last slide, and then I'm on time, Jen. Can you believe it? So just to kind of pull it together, to bring it back to these population level effects, I want to share a mechanisms of change. So take it back to the individual delivery and connect it to the community outcomes before I let Jen and Tim tell you about how they've helped this happen in App Health. So if we look at the trajectory, we deliver Triple P to a family. We see more effective parenting strategies from that family. Those more effective parenting strategies lead to better child behavior because the child has the appropriate environment for that, which leads to decreased stress, like we talked about with morning routines or nighttime routines, common everyday types of example. And when we have all of these things in conjunction, better practices, improve child behavior, and decrease parent stress, we get fewer parents that are abusing their children, parents that use harsh punishment, or parents that are neglecting their children because they have to turn it all off. And so we get lots of reductions in these factors that we've already talked about, plus community level change in parenting practices and child behavior. Another study that's come out, or an evaluation post this, found that they did the same community level tracking but on child behavior and parenting practices, and found huge differences in the community. Again, not tracking individuals who did Triple P, but communities that had it available. So with that, I'm going to turn it over. I don't think we have your slides, Jen, so maybe we can make you. That's okay. I can move that one up and make you.
I'm pretty sure. Okay. I'm pretty sure that I have your slides somewhere, but there were only 2 of them, and they were mainly narrative. So maybe we'll just let you talk. Is that okay? Yes. There's probably 30 or 40 folks back in the room, but they can all see you very well. So tell us about Triple P in Western North Carolina. Perfect.
Yeah.
I have.
I'm gonna steal one really quick because I know that when I was with you guys 5 years ago, that's when I worked over there. There was a huge concern in the community that there were other parenting programs in place, and would Triple P push everyone out? And so how do you work with? Because the only reason I like Triple P is because they didn't do that. So can you talk just briefly so that then other folks can answer questions about that, because there may be some concern about that here. Thank you. Other questions?
Yeah, I have a question. Are there, in the program, are there activities for the kids as well as for the parents, or is it parent focused only?
It's directed towards parents. So all the interventions go directly to parents. There is one variant coming out where the children will be a part of it. It's called Resilience Triple P, which is a program for parents of kids that have been bullied. And there's a direct work with kids around anxiety that comes from that. But it's our first toe in the water for anything with kids. So it is very much delivered to parents.
Okay. And are there any special requirements for trainers? Do those trainers have to be master's level counselors?
For practitioners to
Yeah.
deliver?
Mhm.
Yep. Nope. We are really wide open with that. And as Tim had alluded to, some of the upper levels, particularly levels 4 and 5, it gets more difficult to implement it if you don't have some kind of background in social emotional health or working with parents or kids and families. And so oftentimes those levels are best delivered by somebody, that has a master's degree. But we don't shut out folks otherwise. They can be coached and supported, and so we have no strict requirements with that. It just, in this, I think Jen and Tim did a great job of kind of noting too. I gave you this beautiful picture. That beautiful picture doesn't happen overnight. That it takes some years to put in place and make happen well. And it looks different in every single community. But that implementation planning part of it, that's where that comes in. Sort of working with folks to think about, what are your skill sets? What can you do? Let's take a look at this program. Could you do it with families before we get into the training?
We do have 8 folks in this region already trained in level 2. So there's a librarian, someone at Red Legacy Recovery, Anti-Drug Coalition leader. So we have 8 folks already trained in level 2.
Yes,
So,
okay.
Dr. Kuznets, thanks.
And this question's for Jennifer. I was wondering if you could speak to a little bit more about how you operationalize this at a population-based level. You're speaking a lot towards practitioners, which sounds site-based. So just in terms of relating it more to population-based. Well, just sort of how you see this in your area as population-based approach. Like I say, you were speaking quite a bit about practitioners. Perhaps I don't understand your definition of practitioners in that you're collecting data from practitioners and how that actually describes the population versus the clients.
let me jump, and also I think my understanding too is that it's the media strategy. So in partnership with it is you have the billboards, you have handouts, you have widespread media strategy to normalize help-seeking behavior for parents, so it becomes something that all parents want and need, and they're getting it in schools, medical offices, so around the community, everyone's sharing that message, and there's a huge media campaign that goes with it. So I think that's kind of how it combines to make sure not just engaging the right partners, but that media strategy too. We have several other questions, and I think 2 minutes left. So let's see, Candace, you had a question.
I did. So you said that level 2 was the most successful, correct? And I wondered how you had measured that and assessed that. Was it with regard to building resiliency or something else?
Mm-hmm.
Process.
Yeah. And I'll just jump in, and I think that just to quickly note about the North Carolina evaluation, and it's now in 33 counties countywide, verging on 36 counties in North Carolina. So there is some ask from the state, from the funder, for data to come back in. Part of that is process data on how many families are served, and I think when Tim talks about that level 2 is it's easy integration for folks. It's easy to get it out because that's a brief primary care is a 10-minute intervention with families. But we know, and we talk a lot about the fact that that's not enough for all families. So there are outcome measures being collected in North Carolina as well, particularly for levels 3 through 5, where families get more of that you'd expect changes, and the results are great. You know, there's significant changes on parenting practices, on child behavior. And there is some work that's just been done by some other folks at UNC, still in their public health department, on population effects in North Carolina. Some initial work on the, and I think there was a question she left too, but on trying to measure population level impact. And there's a lot of things that go into that. I think first of all, it's not an RCT like the study was, so there are a lot of other things happening. But we're not going to steer clear of that. And the results, from what I hear, they're being presented on the 20th, are pretty positive around the changes for the counties that North Carolina has been in. And the other part of that is they're now just 5 years in, the first time we might think about seeing those types of changes, because it takes a long time to build this system and build it up. But it comes back to that when we think about doing that well and getting it integrated, that it ultimately is a pretty cost-effective solution when built well. So,
Thank you.
Yeah. Other questions?
We have time for one more. This might not be feasible to talk about, but funding sources generally from y'all, but also just around the nation, and then where Northeast Tennessee is in this process of considering Triple P.
I can give you a couple of lists of our most major funders across the U.S., and then I can let you speak to the Tennessee part. But we have a fair amount of state dollars from state government organizations that go in. So in North Carolina, Jen highlighted the Division of Public Health has been a huge funder. They use their Title V Strengthening Families dollars, their block grant, so federal dollars that are matched by the state, particularly for child and maternal health, to do Triple P in a lot of these counties. Division of Social Services, also part of the HHS, has come on to support almost equally in the last year or two. And so it took seeing some success and seeing that happen first, and then DSS has come on. We've got in North Carolina, we've got one major foundation in Raleigh that supports Raleigh in and of itself. So a private foundation is funding. There are lots of places that are funded by United Ways as well, and in different ways, sometimes smaller scale types of projects, but they're often a contributor. And then we have, outside of North Carolina, we have folks, we have other sites. There's a whole county that's funded by another county funded by a local foundation in Illinois. In Indiana, sorry. In Chicago, it's being funded by the hospital system and the Center for Excellence. In California, funded by their First Fives, so their early childhood organizations. Smart Start's also been huge in North Carolina, that 0 to 5 population. And then some mental health folks have taken it on in California as well. Those are sort of our biggest projects, but it's, quite varied amongst a lot of things.
I think in East Tennessee, other than me talking about it a whole lot for 4 years, I think I know that there was some interest 2 or 3 years ago from Coordinated School Health reached out and had someone from Triple P present in Nashville, and just general interest, and then now 8 certified level 2 providers. That's where we're at.
Can I ask a follow-up question that pertains directly to this, which is, has anybody cracked the code on sustainability? Because grant-funded projects tend to leave at some point.
Absolutely.
Yeah.
And I would say that is always a work in progress. So I would not say that we have cracked the total code to that. But there are a couple things about Triple P that help with sustainability. First of all, we don't pay practitioners. So many parenting programs require that you hire particular staff to deliver this parenting intervention out. We're a workforce development model, so taking advantage of the workforce that's already in place to build up. So the salaries that are dependent are the coordination staff for Triple P, which is crucial. It can't be done without, but it's few salary positions to make it happen. And the other, I think we have had some success in North Carolina in terms of their Title V dollars are recurring. Of course, they're always up to the legislature. It can be cut at any point, but they're pretty consistent dollars that have been funneled. North Carolina also got a Race to the Top Early Learning Challenge grant that funded 17 of the counties in their Northeast section of pretty high need. That was a 2 to 3 year federal grant, and then the dollars were gone. But North Carolina and the leadership there was smart enough to know this was going to happen, and so we moved in July of 2016 to a regionalization strategy. So incorporated all those 17 counties in other regions. So we moved kind of from 17 funded projects to 9 funded projects. And that was able to consolidate, some of the funds there. And then folks I'm really curious to see where it goes, because we get some great examples of how folks will pull on other sectors or other elements and build it in. So folks that are doing one program see how Triple P fits and pull on different dollars, that come in over different times. So that's kind of where we are now with some of that. And of course, there's probably a gazillion other things. Jen, you want to comment?
So there's a program, Family Checkup, right? You guys move and adolescent transitions.
Mhm.
Those are billable, right?
And
Yeah.
Triple P is too,
Okay.
when it's done at the levels they are.
Okay.
I think what Jen's speaking to, if I can kind of put it back in these terms, is that when it becomes a treatment issue, for families, it's not a problem. Triple P's billed like all else. The problem is funding prevention.
Yeah.
So when you try to reach families before kids have diagnosable disorders, insurance companies don't reimburse until you have a diagnosis. So it's kind of one of these broad system, federal system, insurance system barriers to getting effective. So being able to fund folks to do seminars in communities or even in some health practices have just taken it on as part of their wellness part, but others want to bill for it. And you can bill for it, but it's less money, when you bill for this behavioral health consultation in the medical setting. So there's a lot of work, but there's also some policy work moving slowly forward with some of that, and we've had some folks starting to break that. Washington State got a triple P specific billing code for primary care, triple P, so that primary care could be delivered in pediatric well visits and billed for at their normal rate in that state.
That's great.
So yeah, so we're coming, but we're definitely having to kind of continue stepping with these big issues we all.
And I'm sure you're willing to hang out in case
I
folks
am.
have questions, so we're 10
Yeah.
minutes over, and I know several of you have promised it would just be an hour and 10 minutes, but thank you for being here.
Thank you for coming.
Thank you so much.
Try your apple.
Thanks, Jen and Tim.
Bye.
Is there an
We'll talk on the phone
is there an
too.
ideal number of trainers or people who have gotten this training per
Oh,
population?
right. Bye, guys. Okay, bye, thank you so much. We'll talk on the phone.
I didn't know they had that
Bye.
population proposals. So we've got some assumptions that we were
Oregon right now is in the process of completely rewriting a lot of their
how many families in the community that we offer as a starting point. But then it is just a starting point to kind of give a picture. I haven't yet see the rollout of that because, you just take for instance rural versus urban, people all prefer to access services differently. And
That's a good question.
depends on how
I
many
think
folks,
that what we've done
the
is
capacity of the workforce is great.
there is a secure
But yes, the short answer is we've got a starting place and then it's kind of go from there.
So it's not patient.
Already on the
Point where it is collect.
Oh, I
Tim?
secure. So I haven't come across it yet, and actually, I do all, anything that's like that, I review on.
that base.
We need
Oh,
at
yeah.
least the level two people, the 8 people need to start strategizing.
Right.
So that might be a little bit outside of my expertise.
Yeah, I've been thinking about it all the time. We may, you heard a second ago, there's one of the local treatment providers for the opioid use problem is Silver Mountain Recovery. And they're trying to figure out how to get some things integrated and do some of the counseling there.
Details that are
That may be a good convening point, kind of centralized, and we may just want to pull everybody together.
It sounds like that too, what you're saying, so like the 2 and I will say that I do have.
Are you trained? Is anybody else in here trained?
I'll take Sam.
I don't know who was there other than Angie.
I guess we do that on the,
I think it makes more sense.
I guess we do that on the network computer too.
See,
So I typically, my Mac is
and
switched to
then
my.
basically what we're gonna do after this conversation, Emily Merritt is on staff with us at United Way, and is focused on children
Or
and
in
youth.
the
And
very
she
rare
has
exception, my
a
wife has a.
reading program, and she interacts with the
has a
agencies
PTSD,
that we partner with, and so
laptop, I think